Okay, so a warm welcome to all the participants and attendees that are joining us today from all over the world. My name is Kamran Rafiq. I'm the co-founder of the International Society for Neglected Tropical Diseases. Along with the other co-director, Marianne Compere, we've put together, and we're very happy, very delighted to be able to put together this dengue side meeting, a virtual meeting, to mark the occasion of the United Nations General Assembly's 75th anniversary. As we all know, I'm sure you've been following the UN General Assembly 75. The theme, as we all know, the future we want, the United Nations we need, reaffirming our collective commitment to multilateralism, confronting COVID-19 through effective multilateral action. That's the theme for the UNGA75. Why we wanted to have the chance to have have a dengue side meeting, raise the awareness for dengue. Obviously, this is the fastest growing vector-borne disease in the world. We've gone from a situation of 7 countries presenting in the early 70s to over 110 countries presenting today. By the WHO's own estimations, 40% to half of the world's at risk of contracting dengue. And really what we wanted to do today was look at the way COVID, and we're all dealing with the lockdown, it's changing our lives in all aspects of our lives, and it looks like it's going to be, this is the kind of new norm that we are going to have to coalesce around. And the impact of this on issues around dengue control are huge. We wanted to unpack some of these. So we've got 4 sessions planned today. Very, very briefly, the first section is vector control and WASH in the age of COVID-19. The second session, we look at vaccine hesitancy, dengue as a case study in that, and then the case for rebuilding trust in light of the anticipated COVID-19 vaccines that are going to be coming out there. How can we use the dengue experience to rebuild trust? We're looking at then the third session, driving innovation within vector control, and then looking at the end session, really the impact of climate change to dengue control, dengue per se. Huge topics. We've got each session, well, this session will run until 13:45, so we've got 1 hour 45. In this session, we're very happy to welcome Dr. Richard Allan, the CEO of the Mentor Initiative, Dr. Valentina de Laurier, the Health Advisor, the Global Malaria Health Partnerships Advisor at UNICEF, and also Dr. Nani Mudin, Head of the Vector-borne Disease Sector, Ministry of Health, Malaysia. And just joining us now, Dr. Somia Iqtadar from the Government of Punjab, Pakistan, and Chair of the Dengue Expert Advisory Group at the Government of, in Pakistan there. I think without further kind of ado, we're kind of trying to stick to the times. The way these webinar jams work, you have to stick to the time. So I think without further ado, I'll pass you over to the first speaker, Dr. Richard Allan. So over to you. I'm going to mute myself, and if the other speakers could mute themselves and take themselves off video, and then, so over to you, Richard.
Great, well, thank you very much, and welcome to everybody, whether it's morning or afternoon for you, or evening if you're on the other side of the world. We live in a slightly surreal time, and there are some advantages which we can all get together without being face to face. I think the 4 of us are going to give you some different perspectives on vector control for dengue fever. Mine is going to come from very much an experience which is now a lifetime experience of working in disease control in some of the hardest settings around the world, not development settings, and situations which are war zones or natural disasters, for me personally and for the organization I run, are our normal working context. And one of the things I want to really focus on as we look through this is the need to accelerate the integration of WASH and health in order to achieve better health outcomes. Because when we start to do disease control, which involves vectors, in any humanitarian setting, we have to work with a cluster system which was established quite a few years ago now, back in the early 2000s. And that cluster system helps to professionalize and localize skill sets. But for vector-borne disease control, it doesn't fit into any one exclusively, and it actually bridges at least 6 clusters. When you're trying to protect people under shelter, when they're receiving supplies, when they're receiving materials, they're requiring healthcare, they require water, they require sanitation, you end up having to respect and work with quite an interdisciplinary team. Who are we? My team is the Mentor Initiative. I'm very proud of the work they do. We've grown over the years and now work in 10 countries. The 10th, we're about to start launching large-scale dengue fever control programs specifically at city level in Yemen in November time, in partnership with the Ministry of Health and WHO. And it is a very focused set of programs we run, doing disease control to knock out the priority diseases that kill or maim populations at the times when they are weakest and most at risk. And so our whole mantra is to access people where they are hardest to reach. And that means you have to be innovative, you have to be novel, you have to be committed. And our teams working around the world, in many cases, have been there up to 18 years. Some places have not changed in crisis. Countries like Central Africa, Central African Republic, and others have been in emergency for well over a decade. And our teams continue to provide support on the ground. And our learning and experience that I'm discussing comes strictly from our experience and the experience of similar humanitarian organizations to ours, and the complexities we have to deal with on the ground. So innovation and commitment are really important, because in the settings we work in, these pictures really tell you what we're comfortable in. These may not be the holiday destinations of your choice, but many of my team have spent most of their life operating in them. Personally, I've been in these conflict zones and natural disasters now for 35 years. I feel slightly odd when I go on holiday where there's a beach without gunfire going off. But in all of these settings, when they change, and they change radically from urban settings that were constructed well to urban settings which are chaotic, where rubble and destruction and communication and sanitation and services are destroyed, or people are displaced completely from living in the rubble into having to live under temporary shelter, whether they are able to find dry ground or have to set up home in wet ground, they are always more at risk of vector-borne diseases. Which diseases? It changes depending on where you are. But it's starting to equalize out a little more in relation to Aedes mosquito-borne diseases like dengue fever. We've known for a long time that if you look at these emergencies, on the left-hand side, you see the sort of 6 core areas of skill sets or clusters that we work with, all of which are needed if you want to tackle diarrheal disease, malaria, malnutrition, measles, pneumonia, dengue fever, and any of the other Aedes-borne diseases, which are starting to predominate. We're in our 18th year. We're 18 on the 3rd of October. You can send us a card. When we began, the first 3 years was exclusively focused on malaria control in conflict zones. And then the tsunami hit. And we were drawn into Indonesia within 72 hours of the tsunami hitting. And we woke up to the reality that we were having to deal with dengue fever as much as malaria. And so we needed to integrate and expand our skill set for malaria control and make it work for dengue fever as well. Different vectors behaving in different ways, transmitting diseases that ran in parallel and were devastating together. And that was the start of our interventions in dengue control. But it went on because the cyclone Nargis in Burma and then the terrible earthquake in Haiti materialized the same epidemiology. Dramatic humanitarian crisis situations where dengue fever became very quickly it superseded malaria as the main public health need and requirement. And then in 2011, really dengue fever hit into northeast Kenya and Somalia in a very big way. And we've been watching, like a man on a very fast motorbike, somebody accelerate across the continent and across the world without looking back. And that really does describe how dengue fever has been moving. So in vector-borne disease control, we really look at 4 priorities for most humanitarian settings, and then we deal with them depending on which is the priority. But the Anopheles mosquito transmitting malaria, Aedes transmitting dengue, and also chikungunya and yellow fever, Zika, but dengue is the paramount disease. Sandflies across the Middle East transmitting leishmaniasis, and a forgotten vector for many, but houseflies and filth flies, which transmit a huge proportion, perhaps 25% of all the diarrheal disease that we see, not only in conflict zones and natural disasters, but also in poor development settings. And of these, dengue fever is, as Kamran has said in his introduction, the fastest spreading vector-borne disease in the world today. And if it wasn't for COVID, we might be saying it was indeed the fastest spreading disease that we have in front of us. It's been extraordinary, both in the number of countries it's jumped to, but also in the scale at which it achieves on an annual incremental basis. And the main reason for that is that the vector that transmits it, Aedes, is geographically, it's got a huge global coverage. There are a few places without Aedes, even southern England, though hopefully it'll always be too cold, but maybe not. So why does dengue feature really heavily for humanitarian crisis settings, emergencies? Well, people, when they're caught up in these crises, they become victims. They either have to hunker down in very damaged buildings with damaged infrastructure, as we said, or they're displaced and they may be on the move, living rough. They may be living under poor shelter, not just for weeks or months, but sometimes for years under temporary plastic sheeting. Water container management. Water has to be brought into people when they're displaced or when their city infrastructure is destroyed. And the dependency on water containers rises disproportionately from normal. If you've worked in cities like Aleppo in Syria, you'd know that piped water, which once was normal as it is for us, became abnormal, and the dependency on water barrels and systems became the norm. That's true for most humanitarian crises. But equally true is that waste container management is almost certainly dropped, and normal systems for waste clearance are destroyed, and the infrastructure is destroyed. And that creates breeding sites for mosquitoes that weren't there before. Malnutrition, a really common overriding factor, also creates a deficiency in the human immune response. And that makes people more susceptible to severe disease when they become sick with dengue. And at the very time you need it most, in these crisis settings, access to good health facilities for diagnosis and treatment is very low. And in some cases, it's zero. And on top of that, there is no antiviral treatment for dengue. So we just cope with dealing with symptoms and trying to manage the worst. And what is the worst? Well, we know that children are hugely affected as the high-risk population or sector of the population in these crisis settings. And if you've seen Ebola in any form or other, I can assure you, and having worked in Ebola and Lassa fever, there's no difference with dengue fever. When you see cases of children bleeding from their face, it's extraordinarily distressing. And you know that once a child reaches that stage, the chances of a good prognosis and outcome are slim, and the chances of death are high. So children are hugely at risk. I said it's because the Aedes mosquito breeds really well, and we have a fantastic ability to create more breeding sites as a result of destruction. These mosquitoes will lay their eggs on any damp surface, into pots, storage containers, large or small, old tires, bottles, even plastic bags that are left discarded. So it's not surprising that then when we look at crisis situations where water is supplied as a a measure of the humanitarian response to meet a very basic need, drinking water. In so doing, we often create the very Aedes breeding sites that we have to then control. And so often we create the outbreak setting in settings where people's immune systems are least able to cope with a new disease. So how do you control it? Well, our experience has been that always keep things simple. But what we must always do is remember that dengue control, essentially, if you want to achieve it at really effective levels, it has to be at community level. The communities themselves where the mosquitoes breed inside the households are the ones that are really key actors in this. And it doesn't matter whether it's a development setting or a crisis. People are people, and they are always part of the solution. Emptying and cleaning water storage containers like this family in Indonesia, really important on a once-a-week basis. It gets rid of the eggs that have stuck to the wall linings of the water storage containers of different sizes. If you can manage them physically, you can clean them. Burying and getting rid of old bags and tins and bottles that might be in the garden that would collect water and still provide a perfect Aedes breeding site. Turning over old coconut shells, making holes in tin cans so that they can't hold water, and putting covers on, tight-fitting lids that won't let mosquitoes enter into those containers is another key, simple manual method. And for some, and we've done this ourselves in the middle of the crisis in Burma, introducing fish-eating larvae or copepods, can work very effectively too, because the fish are so small, people don't want to eat them. I'm not sure it'd work in most African settings, but in Asian crisis it did. Larviciding is another key tool, and I said in the earlier slide that control is achieved both environmentally and chemically. You can't avoid the use of chemicals, and there's been fantastic developments with chemistry for larviciding in recent years, and very reliable historical larvicides, and simple to apply, safe dosage insecticides, using spoons as our team have in Haiti and other places, or cups, depending on the size of the water barrels that are being standardized on, is a very straightforward way to make water safe and to ensure that there are no larvae developing and emerging as adults. But as important water sources are, and water storage systems, we often forget, not just in crisis settings, but outside of, that waste management is just as important if you want to have effective dengue control. If you have populations which are strained and stressed, if you have camps, if you have destroyed urban settings, it's not uncommon to find waste sites like this one as high as a house and maybe as large as a football field, as we found in different urban settings under heavy fire, where systems and services have been cut off for a long time. These are filled with breeding sites. They hold anything that will hold water, will create a breeding site for a mosquito. And so managing waste is as important as managing water storage. Getting rid of this, removing it away so that it's not close to a residential area, or burying it or treating it, are absolutely essential activities that we're engaged in on an everyday basis. How serious is this? Well, as Kamran said, this is a disease which, like the vector, is spreading very, very fast in its ability to take root, initially with outbreaks and then to become entrenched in a population and seasonal. This is just a view of the last year, with cases in very large numbers, the largest ever. So every year seems to be a record year for dengue, and 2019 was the highest recorded number of dengue cases ever. And that's with one of the poorest surveillance systems we have available to us for any disease, because the diagnostics for dengue are still pretty rudimentary and not highly available in terms of a public health availability. But notice on here that cases in Spain and France are also there, and they've been there for the last decade. Every year, more cases occurring. Yes, we have appalling problems in the Philippines and Nicaragua and across Brazil, but we have outbreaks in Yemen that devastate a population already malnourished and on its knees. And the death rates associated with that are as yet unmeasured, but we know that they're very different from other settings. So outbreak surveillance is really helpful, certainly at early stage settings where dengue is starting to emerge, because they help to direct community-based campaigns, tell you where to put your efforts. Strengthening diagnostics and treatment services, it's absolutely essential for all the severe cases that result as a larger number of people become infected and as more serotypes of dengue become established in an area. We know that effective and safe vaccines are still a work in progress. There's been steps forward and steps backwards. You'll hear more of that in subsequent sections. But at the end, you're left with a very clear conclusion that given there is no direct treatment of the virus and not yet a safe and effective vaccine that we can use at large-scale public health levels for emergencies, community-based vector control has to be the way forward, at least for now, and probably for at least the next 5 years. It's low cost, and it really works. If you do it well, we've got very good documented evidence from many settings of 80% reduction in disease. But that success is really dependent on people. People, because you need to engage them and mobilize them, and you need to be able to use new tools. As Kamran said, COVID-19 has created problems for many humanitarian agencies, for many responses, for many normal health systems to deliver normal work. In our experience, though, we can attest that actually COVID-19 responses, which are basically designed to change human behavior and improve hygiene behaviors, get people to wear masks, get people to wash their hands and socially distance. Actually, we have a unique opportunity through dengue prevention at community level, because we access so many people's homes and we have face-to-face contact with every family in every population that we target. And we found that it provides a unique way of bringing COVID messaging very quickly added on to dengue control, allowing us to have that face-to-face contact at the same time as doing integrated vector management in the cities, in the towns, and in the villages and rural areas. And we've been able to very quickly, within a matter of a week or so, bring in effective COVID-19 IEC. And it's helped, not hindered, our ability to do community level responses. Not to bring people together en masse, as some programs might do, but by delivering at household level these interventions, we avoid all the problems of gathering populations together in a non-distance method. So I'd just like to finish with a thought process, which is, having started and being known for malaria control and emergencies, I think most of my life, I put value on the 25th of April every year as a method for bringing together global political will and funding will for malaria. And I'd just like to say that in a setting of history where we're faced with the fastest growing disease transmitted by insects that we've ever known in history, it's time for a World Dengue Day. Let's use that to try and galvanize the political and funding support that so far has not been behind dengue control. But if we are to stem its movements, if we are to stem the scale and the devastation of this disease, not just in developing countries and crisis zones, but also on the streets of our French and Italian coastal tourist resorts, we need to take it more seriously, and we need to bring more of a galvanized global commitment to dengue control. Thank you very much.
Thank you very much, Richard, there. A virtual round of applause. A wonderful presentation, really highlighting the spread of dengue and your unique perspective on it in terms of the from the actual communities you're working in, how COVID is really kind of giving an opportunity. It's a positive story, and that's one that we wanted to kind of put forward, especially given the overarching aim of the UNGA, the theme, the multilateralism confronting COVID through dengue certainly has a part to play. You alluded at the end there to the World Dengue Day. We've been running, for those of you who are unaware, we've been running here at the ISNTD, it's been about 2 years now, a global campaign, a sustained advocacy campaign to get the WHO to ratify an official World Dengue Day. We've built up lots of support. We have a dengue advisory group, which Richard's part of, Dr. Rose from the Ministry of Health Malaysia, Dr. Somia Iqtadar, also from Pakistan, from the government there, part of the dengue advisory group. We're really pushing for that, and we have a live petition on change.org with over 26,000 signatures rising. So we are really going for that. It's really good to hear how the Malaria Day has galvanized the effort in malaria. We certainly think dengue needs its own day. So thank you very much for highlighting that, Richard. I'm going to pass quickly to the next speaker, Dr. Valentina Budge de Lawarrier from the Global Malaria Health Partnerships Advisor at UNICEF. Richard mentioned there 90% of the at risk of going on to contract severe hemorrhagic fever are the children, and we thought it'd be very interesting to have UNICEF, which has been active in WASH in various settings, in this space for some time, and get that kind of perspective. So without further ado, a virtual round of applause for Valentina, and I'll pass the floor over to you. So over to you.
Thank you very much. And it's always a hard act to follow Dr. Richard. But I'll give you two small, tiny, trivial details. One of which is I was on the drafting committee that put forward to the WHO the resolution that passed the World Malaria Day in 2007. So it's been a long time coming. We built off of the Africa Malaria Day. And then just to show my commitment as a malaria advisor, I actually got married on World Malaria Day 5 years ago. So it also happens to be my wedding anniversary. Following on from Dr. Richard, I thought I'd do a little deep dive. And in order to do that, I have just a few slides to show you, which show how a cross-sectoral program can work across child protection, WASH, health, communication for development, and leverage community engagement. Just to sort of delve straight into it, as Dr. Allan very well presented, vector-borne diseases actually account for more than 17% of all infectious diseases, and they cause more than 1 billion cases and more than 1 million deaths annually. We know that more than 2.5 billion people in over 100 countries are at risk of contracting dengue alone. Other diseases such as Chagas disease, leishmaniasis, and schistosomiasis are also affecting hundreds of millions of people worldwide. Not to mention malaria, which we know causes more than 400,000 deaths every year globally, most of them in children under 5 years of age. This is just a short schema on how and where we've seen case burdens rise worldwide. Dr. Richard, I think, did a brilliant job of showing how this is not just a problem of the global south, but is now also beginning to incur in the global north. And as he says, on the beaches and on the hotels of France and Italy. We know that the disease burden of vector-borne diseases is increasing because of war and conflicts, but also because of disasters. We don't have an effective vaccine except for yellow fever. We are seeing increasing vector resistance, so increasing resistance to insecticides. Plus, the parasites are also developing drug resistance. We are seeing population growth in endemic areas, and we also see substantial population migrations. As Dr. Allan presented, vectors have a very particular importance in emergencies. Situations become very precarious, regular control measures break down, we see new breeding grounds being created, and the parasites can now invade new and vulnerable communities. Populations will also have more or less immunity as they move into new areas. And of course, the rapid spread of vectors is propagated by poor sanitation and poor hygiene, especially in overcrowded settlements. UNICEF has a core component, its malaria strategy, which increases access to life-saving commodities. We also focus on increasing investments and resource mobilization. And we are focusing very clearly on integrating malaria interventions into health systems. This will help us to better target vulnerable and marginalized populations as part of our equity agenda. Plus, we also use and improve the quality and use of data by communities, as well as strengthening and facilitating cross-sectoral engagement. All of this underpinned by a very strong investment in community engagement and particularly strengthening social and behavior change communication. As Dr. Allan presented, we do know that vector-borne diseases can be prevented. Early case reporting, diagnosis, and treatment are very important. And as he outlined, there are 4 important means of prevention. We can kill the adult mosquitoes. The responsibility lies primarily with governments and households. We can also prevent mosquitoes from biting. And the primary responsibility relies on changes in household behaviors, plus also ensuring that retail markets are available to provide the necessary commodities. We can control mosquito breeding, which is again the responsibility of communities and governments. And where possible, we can provide vaccines and anti-malarial drugs, which is the responsibility of governments to provide these to these populations and communities to ensure uptake. Now to go a little bit more into the challenges, just very briefly. There is not only insecurity and lack of access, insufficient human resources. We know that supply systems are weak, especially to reach the last mile. Infrastructure is often old and dilapidated in the area where vector-borne diseases mostly occur. As Dr. Allan outlined, we often have weak coordination. The global availability of stocks can be poor. This is also underlain by inadequate funding for these diseases, unreliable or poor information and data management systems. The strength of the health system will also underlie the response. But then on a slightly softer side, or a more economic and social political side, we know that social norms and cultural practices will also undermine uptake of commodities. Fears and rumors and misconception and misinformation will also reduce uptake, as well as the socio-political context in which we're trying to introduce interventions. As Dr. Allan said, it's always important to ensure that we are looking at surveillance and investing in surveillance interventions, such that we can see where a disease may arise or where larger scale outbreaks and epidemics may be occurring. However, we know that this is one of the most under-resourced areas in most national strategies. If we go a little bit further into emergency settings, it's not only important to think about how we will have exposure to the vector, but also what are the characteristics of the population. This will involve not only leveraging the information from entomologists, but also from health specialists who can tell us what is the endemicity in the area, what are the biting and breeding habits of the vector specifically, what might be the population's immunity status, and is there any access to health facilities remaining? Can we identify community-based health workers who may have traveled with their communities and can help ensure continuity of services? As Dr. Allan said, it is very important to ensure prevention, but that is not only about ensuring that there are bed nets available. We have to think about how we can get them to the populations in need. We also have to think about the parameters of the context, including, for instance, if we think about malaria, that bed nets may not be the most adequate tool. It might be more necessary to use blankets. And if everyone is outside, there may not be structures to hang bed nets. In other situations, we may have to think about indoor residual spraying or integrated vector management. But that requires trained specialists, and we must ensure that there are cadres of professionals who can help ensure the spread of these interventions. On the converse side, once our population is infected, we must think about case management, and that will require not only being able to ensure we have the right diagnosis for the right disease, but can we also provide the right treatment? Are there drugs already available for the disease, or will we only be able to provide palliative care? As I said, one of the most important and most under-resourced areas is capacity building and advocacy, communication, and social mobilization. Very rarely are resources provided to ensure that the community is well sensitized, has access to information, and can also dispel rumors and also ensure early care seeking, which is vital to controlling the disease, spread, and transmission. Thus, it is an important adherent for vector control actions that we ensure we have good community engagement. This ensures that we must have liaison sections and community advocates. We are well aware that communities mostly listen to their own advocates. Everyone wants to hear something from somebody that they trust. Thus, we must identify advocates in the communities themselves. We learned that dynamic listening and public engagement in Brazil was extremely important to stemming the spread of Zika. And there's a small picture there of how we were working with different communities and sensitizing new mothers as well as their children. As Dr. Allan said, coordination is often a systemic challenge, and thinking about how roles and responsibilities will not only be distributed, but actually acted upon. Now, when we think about why do we focus so much on prevention, especially for vector control, for vector-borne diseases, the main problem is that there are high costs of treatment and management, and the high costs are borne not only by the health system, but also by families and economies. We know that the cost per every hospitalized episode of dengue in public hospitals can rise as high as $866,000 in Sri Lanka. However, we've seen, especially from most of the studies done in malaria, that while malaria is estimated to cost a minimum of $12 billion in lost productivity every year, the benefit cost ratio of investing in malaria control and elimination ranged from 2.4 to over 144. Thus, the return on investment is extremely high when we think about controlling vector-borne diseases. Because I cannot get away from my day job, a lot of these slides will focus, but we looked at what is the benefits of vector control, especially when we start thinking about eradication campaigns. The benefits are not only economic, they are also systemic investments in future generations. For instance, in Uganda, eradication efforts produced 0.3 years more schooling in each intervention areas, which corresponds to annual income gains of 3 to 11%, extremely high for very poor societies. We also know that malaria will undercut average time lost from work by 1 to 5 days. Farmers who actually use their bennets can increase their harvest by up to 15%. In terms of dengue, we know that when we invest in vector control, we can save upwards of hundreds of thousands of dollars, up to $6.46 per inhabitant once we invest in control interventions. And in Cambodia, a study area of 2.9 million people, the intervention reduced numbers of dengue cases and deaths, averting nearly 3,000 hospitalizations. It is extremely important that we think about, as Dr. Allan said, the sustained use of vector control technologies, because it is the sustained reduction of vector populations that will actually lead us to saving lives and saving productivity time. We have also a number of different cases from Zika and from Colombia, as well as the Guillain-Barré syndrome and microencephaly cases, which also have systemic losses over the lifetime of the individual. Some of the lessons learned is that prevention offers the most cost-effective approach to Zika transmission management. In particular, we have to think about engagement and awareness. Communities need to be educated on how vector diseases spread, the symptoms of disease, and the personal responsibility that they can themselves take for their own health. We need to use all points of contact and reinforce positive behaviors. A sense of shared responsibility will ensure that national and municipal governments can prepare action plans, establish routine surveillance, and ensure the uptake and use and provision of vector control supplies, as well as rapidly responding to indicators of outbreaks or increasing disease burden. It is very important, especially in resource-constrained environments, that we do stratify. When resources are scarce, it's important to target them in areas of highest burden. We are very clear, and I must say this as a global expert, that no expertise can substitute for local knowledge in planning. As an example, and these are my last slides, multi-sectorial support is extremely important whenever we are, even if we're talking about a single disease. And within UNICEF, our malaria program not only relies upon the health sector, but also WASH, education, health system strengthening, nutrition, communication for development, and even looking at the opportunities presented by immunization, especially as we think about the introduction of the malaria vaccine, as well as thinking through early childhood development and adolescence. We have produced a number of multi-sectoral tools, in particular a cross-sectoral primer on vector control actions for IETs, as well as the anopheline-borne diseases. And we have produced some of these summaries thinking through where do we need to invest in data, such as surveillance, how do we control larvae, which is mainly interventions from WASH, but also what is necessary to ensure environmental management, as well as personal protection for communities. And my last slide is just a small primer on factors for success. We do need the involvement of several partners, particularly the local community. Integrated interventions are the most effective method for control. We need multidisciplinary and multi-sectoral involvement. Again, I cannot stress how important community participation is to ensure that we have effective control, social mobilization campaigns, and control must be early in an outbreak, and the tool must fit the context. Highly visible, highly expensive interventions do not equal effectiveness. And with that, I thank you very much, and I look forward to your questions.
Thank you very much, Dr. Bouge. Valentina, thank you very much for that. Very interesting that all of the kind of gaps that you've highlighted and all the necessary steps all seem to revolve around the community and making that community an asset in terms of sustained vector control, really highlighting that in your presentation. And very interesting, you talk about the need for multi-sectorial, the pressing need for multi-sectorial involvement. It's very interesting because it's really in line with the WHO, their roadmap in NTDs to 2030 had described, released earlier this year in January, really described three kind of shifts, moving from the pragmatic kind of approach to a more real life impact measured of success for any kind of program. Also from a vertical disease specific to a more cross-cutting approach, this multi-sectorial approach. And then their kind of third shift in the way they want to get to this their targets, moving from a kind of external to a more sovereign-based, country-owned model. I'm mentioning that because all of that's underpinned by the community itself. I think you've highlighted that the three changes that they want to kind of put in charge really are all about recognizing the community and engaging with them. So I think that's a very in line and very interesting presentation. Thank you very much for that. I think UNICEF and the Mentor Initiative have got unique position in terms of working with those communities on the ground so they can really hear what's needed and really see that. So thank you very much. A round of applause to you there, Valentina. That brings me to our next speaker, Dr. Rose Nani Mudin, the head of Vector-borne Disease Sector at the Ministry of Health, Malaysia, who could probably shed a bit of light in terms of what's actually going on there in terms of the community's engagement and vector control in the age of COVID. So a round of applause, Dr. Rose. Assalamu alaikum. And I'm gonna mute myself.
Yeah, thank you. Thank you very much. Okay, very good day to all the distinguished participants of this event. Thank you to the organizer for giving Malaysia opportunity to share our experience in implementing our dengue control measures during the COVID-19 pandemic. And this gives us a lot of challenge while doing our control activities. This is the contents of my presentations. It will go on about the chronology of movement control order in Malaysia, the dengue trends, the critical actions for control of dengue in MCO, that what we have done and is ongoing until today, and the challenges and the way forward, and also the conclusions. Starting early of January 2020, I think WHO started receive reportings of the COVID-19. Previously was known as a coronavirus infections. So in Malaysia, on the 25th January 2020, Malaysia received reports of imported cases mainly from China. And at that time, China was the most affected country of coronavirus infections. And we didn't have any cases until late February 2020, where the cases of COVID were reported in Malaysia, and starting on the 18th March 2020, movement control order officially enforced in Malaysia by the decision made by the National Security Council. And the MCO were enforced in 4 phases and continue with enhanced MCO and conditional MCO, and until now is the recovery MCO. During this, during the implementation of MCO, we face during the initial phase, we face uncertainty. And many questions came from our staff and also from the public about the COVID-19 infection and about how we are going to do the control measure during the pandemic situations. So this was one of our major challenges during this pandemic situations. And of course, the decisions mainly made by the National Security Councils and also the Ministry of Health on how to go about on the implementation of MCO and when to start and where, and of course involvement of multiple ministries and agencies in carrying out the MCO and developing standard operation procedures, including guidelines for the public in view to prevent COVID-19 transmissions, were actually implemented during that time. And the MCO actually continue until today. Now we are in the recovery MCO phases, and Malaysia are still reporting COVID-19 cases, and until 23rd September 2020, which is it was yesterday, Malaysia reported about 10,505 cases with 133 deaths from these infections. And if you can see on the right side of the slide, there is the chronology of the movement control order that happened in Malaysia starting from 18 March until today. And even during the movement control order, our surveillance for vector-borne diseases continues without disruptions, because all of our surveillance systems are real-time web-based surveillance systems. So we do not have any interruption of services in terms of surveillance of the vector-borne diseases, especially for dengue. So if you can see in the graph, the MCO started 18 March, which is around 11 epic week, and you can see that the number of cases reported for dengue reduced. And this is not only happened for dengue, but all other vector-borne diseases and also other infectious diseases. And as early as 24th March, which is 1 week after the NCO enforcement, Ministry of Health, Vector-borne Disease Sector under the Disease Control Divisions already come out with formal administrative order on the critical action needed to be done by the dengue control team at the ground. And later, on the 19th of May 2020, we come out with formal administrative instructions for all vector-borne diseases control measure, that what is need to be done at the ground level. So it is very important for the program manager to decide, especially during the pandemic period, because most of the time people were uncertain, including our health staff. They were uncertain, they were afraid of being infected by the COVID-19. So you need to give guide to them. Besides that, you need to also facilitate and provide personal protection equipment for the staff to carry out their activity at the ground. And we develop guidelines or standard operation procedures based on the zoning that was given by the National Security Council and also by Ministry of Health. This zoning is based on the number of COVID-19 cases reported in that area. So, for example, for green, there is no cases reported for COVID. Between 20 to 40 cases, they stratified this as a yellow zone, and if the cases are more than 40, it will be called the red zone. So we look at the dengue surveillance systems. Our intervention, it was continued during the MCO because we have a real-time web-based surveillance system regardless at any area, either green or yellow or red zone. With regards to the routine case investigation and detection, this is also being carried out in the three zones, either green, yellow, or red, because this is very critical. Once you diagnose the patient with dengue, you need to give a treatment to this patient, and the case detection must be continued during this MCO, because dengue can also kill as just like COVID-19. And all the cases that reported to Ministry of Health will investigated immediately, but with the adjustment that our health staff will need to use personal protection equipment. They have to use facial mask. They have to apply physical distancing, 1 meter from each individual, and also they have to apply frequent hand washing or using hand sanitizer while doing their activities. And in the case management, it was continued in either green until red zone, because this is very important to make sure that the patients are safe and the treatment are given appropriately. In terms of outbreak, you also give priority of management of outbreak even during the COVID-19 pandemic, because this can actually create major transmissions in the community if it is not well controlled. So the activity, for example, case detection, active case detection, case management, and vector control were still carried out in this in that particular area. However, for entomological investigations, some of the activities are deferred, especially in the yellow and in the red zone. For vector controls, especially in the outbreak localities, it will still be continued during the pandemic situations. And however, for the routine surveillance, it was withhold. The activity was withhold if there's a area of COVID outbreaks or in the red zone or in the yellow zone. And our supply for diagnostic tools for dengue, we use a combo rapid test kit for NS1, IgM, and IgG for all the suspected cases. If they have symptom and sign of dengue, the test will be carried out to all these patients for confirmation of the case. And we did not have any problem with the supplies because we procure in a large amount early of the year, and we usually calculate our needs until end of the year. So we did not any interruption of supply of equipments. In terms of control, dengue control activities during the pandemic situation, we need to adjust certain activity. We just do the critical activity. For example, in the case where the dengue case reported within 200-meter radius, the breeding place destructions activity, fogging, and ultra low volume sprays and larviciding are still being done, except in the red zone area. If it's possible, we also integrate the activity with the staff that going to this red zone area. So they are not the vector staff, but they are the COVID-19 staff, which they also doing, helping us doing the activity, because this area is guarded, because not everybody can go to the area because it's very infective for COVID-19 infections. And even during the MCO or during the pandemic situation, we still carry out our ASEAN Dengue Day campaign, which is we celebrate this Dengue Day campaign every 15 June annually. And however, we need to modify our method of observations of this Dengue Day. We use more media, social, digitals, and for example, WhatsApp, Facebook, televisions, and radio on the campaign, just to create an awareness to the community that even during the MCO, they need to do premise inspection inside and outside the house weekly, so that there won't be any Aedes breeding places in their area. So this campaign is conducted at the national level, at the state level, and also we have 15 states. Nearly all 15 states are doing the campaign for at their own area. And we also have a campaign at the community level. So we have a community who are going to give a talk in the, for example, in the televisions or in the Facebook, live Facebook, and also giving advertisement to their neighborhood. And in Malaysia, we already implemented the novel vector control tools for in the dengue prevention and control program. We implemented this Wolbachia mosquito operation release in our dengue control program, and we started actually in July. Just to give a brief overview on what is Wolbachia all about. Actually, Wolbachia is a bacteria which is injected into the Aedes mosquito eggs, and when this Aedes mosquito grow to become an adult mosquito, they carry this bacteria inside their body. So this Wolbachia actually exists in 60 to 70% of the natural insect, such as flies, butterflies, grasshopper. And how does Wolbachia help in the in prevention of dengue infection? The Wolbachia actually prevent the multiplications of virus in the mosquito's body. So this is how the transmission of dengue virus will be prevented from one individual to another individual. So in Malaysia, we are using either both suppression or replacement method, and this is just a brief summary on this Wolbachia project. And during the COVID-19 pandemic, of course, we have a challenge in doing our activity. Even though we started July 2019 and we implemented in the 17 localities starting from July 19 until today, and I think because of this, the novel tool, so most our staff were actually worried when they have to go to the ground, because during the implementation of Wolbachia, they need to go frequently to the ground for the release of Wolbachia mosquito. They have to go at day 1, day 5, day 8, day 1, day 5, day 8, and day 15. So that's why we had slight problem during the initial phase of MCO. And during this MCO, we need to adjust our operations method, but all the activities continued with the adjustment. So we modified our standard operation procedures, and instead of releasing eggs, we are releasing our adult mosquitoes, so that the procedure become much lesser compared to releasing eggs. And of course, our staff, when they go to the ground, they need to apply the personal protections against COVID-19 infections. And for this Wolbachia mosquito operations also, we came out with administrative order on how they have to do and conduct the activity during the pandemic situations. Before the MCO, the community engagement for this project, they go face to face, they go house to house, they have a community gathering, a big community gathering. However, during the MCO, all the community engagement approach was adjusted to different methods using media, socials, WhatsApp, Facebook, website, and phone call, and etc. And our achievement for this project, even during the pandemic situations, our activity and operation continue during this MCO. Community engagement also continue, and majority intervention locality shows reduction of dengue cases, and the impact of COVID-19 pandemic and MCO on implementation of Wolbachia project was minimal. This is our picture of our Wolbachia teams at all level, and of course after the 4 phases of MCO, we have to adjust our standard operating procedures, because during this period it was less stringent and people can more mobile, and more activity can be done at the ground. So if you can see here, after the announcement of MCO, where we have the enhanced MCO in the beginning, we went to the recovery MCO, so we have to adjust all the activities with the new norms, but the activity continues as I mentioned before, based on the zone. Again, red zone, we still have to apply all the standard operation procedure according to the COVID-19 pandemic's procedures. However, all the activities are continued until today. And now, in terms of training, monitoring at the ground, is we can do more frequent this activity compared to previously, and even our surveillance activities is also continue as usual. Also including the prevention of outbreak and also activity with the community. So these are the activities that are now being carried out based on the standard operation procedures that already provided by the program manager. The challenges of the vector-borne disease service delivery during COVID-19 was because of the movement control order. It limits the movement of our health staff for doing prevention and control activity, and also limits the movement of the individual and the community to access the health services. And this also affect our volunteers. We have about 28,000 volunteers, dengue volunteers with us, who is doing their activity weekly. So during the initial phase of the pandemic situation, they have to withhold their activity until they are sure about the situations, and they continue with the activity later. Interruption of services delivery in the community, where the community were unable to, we were unable to enter their houses, and we were unable to conduct control activity inside the house. For example, especially IRS or inspections of the premises. And for example, no mass gathering are allowed. So this actually affect our mega cleanliness campaign that we have 3 times a year for every year, and now we won't be able to do the mass gathering anymore. So during the mitigation of COVID-19 infections, we also have to it is also applied to our vector staff, and we also have to consult our health staff and share the update status of COVID-19 situation in their area to ensure that, and to convince them about their safety when they are doing the activity. And this now our volunteers are applying new norms when they are doing mass cleaning. However, the mass cleaning is with less numbers of participants, and they also applying social physical distancing during the activity. And they also apply a facial mask when they are doing the activity. So way forward, strong program leaderships at the national level is important during the pandemic situation. And we have our National Dengue Task Force in Malaysia, which is led by our Deputy Prime Minister. And this Dengue Task Force are still functioning even though during the pandemic situations. Critical intervention for dengue control must continue even during the MCO, and critical intervention harmonizations for dengue and COVID-19 are important during these situations. For effective planning, the program requires continuous updates of COVID-19 situations, example, the epidemiology, mode of transmissions, and guidelines, a new guideline or new SOP. For effective implementation of critical intervention on the ground, health staff must be updated and convinced on the safety measure. Electronic and social media are the best platform for communication during these situations. And dengue prevention and control program must adapt a new normal from now on. In the pandemic situation, the program must use innovative methods in delivering of service for the disease prevention and control. And in conclusions, with the increasing global burden of dengue, the critical interventions of to prevent this disease must be carried out even during the COVID pandemic situation. Multi-sectorial and multi-agency involvement, as mentioned by Valencia and Dr. Richards, it is important, very important, and especially at the national and also at the global level. This call for a platform to initiate concentrated efforts regionally and globally. Therefore, World Dengue Observance Day is proposed for this purpose. And establishment of global dengue network, it is important to facilitate efforts against dengue. And this just sharing the pictures of during the COVID-19 infections. And with that, I end my presentations with this video.
Walaupun kita sedang berhadapan dengan pandemik COVID-19, aktiviti pencegahan denggi mesti diteruskan dengan mengamalkan norma baharu. Setiap individu dan komuniti perlu membersihkan persekitaran di dalam dan di luar rumah masing-masing. Hapuskan tempat pembiakan nyamuk Aedes. Luangkan sekurang-kurangnya 10 minit untuk mencari dan memusnahkan tempat pembiakan Aedes. Hashtag 10 minit. Hapuskan Aedes.
I just want to say thank you very, very much for a wonderful presentation, really highlighting the robust national program leadership in terms of the combining the COVID effort and its impact to your dengue effort. Amazing to see all the processes in place. So thank you very much for highlighting that and explaining that. Some very interesting comments coming through from some of the attendees as well regarding that. So it's very well received. So thank you very much. Round of applause, and I'll come back to you in one second.
Thank you.
So I'm just going to hand over to the next speaker, Dr. Somia Iqtadar from the Government of Punjab, Ministry of Health, Pakistan. We're running kind of low on time, so I'm going to quickly hand you over to Somia. So over to you, Somia. Yep.
Thank you very much, Kamran, and thank you, ISNTD, for this important event. So, ladies and gentlemen, we are at war with mosquitoes, a swarming and consuming army of enemy mosquitoes. They patrol almost every inch of the globe. And the biting female warrior of this droning insect population is armed with lethal and debilitating biological weapons to be used against billions of humans. And you can see here that it's the world's deadliest animal, and it has contributed to more than 830,000 deaths in year 2015, which is by far the most reported on the earth. And if they bleed, then you bleed and I bleed. And out of these breeding mosquitoes, 2 mosquitoes that are causing a lot of harm to us are Aedes aegypti and Aedes albopictus, which are responsible for not only causing dengue, but yellow fever, Zika, and chikungunya as well. So today I'm going to talk about the small bite, which is a big threat, and I will be sharing with you tackling the dengue epidemic in Punjab, Pakistan, and I will be sharing my experience from my country. In this presentation, I was assisted by my colleague from Punjab Information Technology Board, who gives technical assistance to all the dengue control program in the Punjab, Mr. Shahryar Khalid. So the story began actually in 2011, when Punjab, which is the biggest province of Pakistan, faced the worst ever reported dengue epidemic in the world. We didn't know much about dengue before that because there were only occasional cases reported from the country. But in 2011, we were attacked by this army of mosquitoes loaded with this virus dengue, and we were caught unprepared. There were approximately 0.6 million suspected cases and 22,000 lab-confirmed cases in a short span of 73 days. And this has been reported as the world's largest epidemic so far, and we lost 325 precious lives due to this. And in a very short span of time, the cases, they started emerging, and the deaths, they started increasing day by day. And since we didn't have any previous experience of coping with the outbreak of a disease, which was not much known to us, so all our efforts were based on simple mosquito control. This was the situation in the hospitals where thousands of people were coming every day with fever and low cell counts. And there was a huge struggle to get a bed in the hospital, and we had to convert all our major hospitals into dengue hospitals. But the situation changed and we were able to control this disease. And I very proudly say that this is a success story for Pakistan as far as control of dengue is concerned. So we were a bit relaxed in the subsequent years when in 2013 and 15 we were hit again by an epidemic. And later in 2019, when there was a global surge of dengue cases, especially in the Southeast Asian region, we were hit badly again in another. Firstly, in 2011, it was Lahore, but in 2019, our Pindi district, which is near the capital of the country, Islamabad, it was hit by a dengue epidemic. And we had about more than 50,000 confirmed cases, which were few thousands in the previous years. So if you look at the pattern, I basically look at the Punjab province, which is the biggest province of the country. So if you look at the pattern, that you can see from year 2016, there's a surge in the number of cases and in the spread of the disease. Red is the color which is depicting the more number of cases. And you can see that it started, sorry, from few districts, and then it reached most of the districts, and almost all the districts of the province are affected by it. So what steps did we take which led to a successful dengue control program? The most important step was the advocacy and the political commitment. So we formed the Central Emergency Response Committee, which was daily chaired by the Chief Minister of the province. There were town emergency response committees and district emergency response committees, which met very frequently. And then finally, we launched the Prevention and Control Program of Epidemics in Punjab, which looks after not only dengue, but other vector-borne diseases and communicable diseases as well. I must appreciate the efforts of international experts and support of the international experts. As I told you in the beginning, that we were not well prepared and we didn't know much about this disease. So we got help from Malaysia, Indonesia, Sri Lanka, Singapore, and the neighboring countries, which helped us in identifying the dengue larva, Aedes larva, the mosquito, and helped us in development of clinical management guidelines and training of our doctors. So the government took an initiative of sending 110 people to Sri Lanka by the collaboration of Ministry of Health and Asian Institute of Technology, Thailand, for training as master trainers in the dengue. And this was known as the Dengue Epidemic Prevention, Control and Management Program. In this 3 weeks course, they were trained on all aspects of dengue, from field management to the clinical management. It had different sectors consisting of virologists, field operators, environmental specialists, public health specialists, lab workers, and clinicians and pediatricians who were looking after the dengue cases. So they all came together and they learned the details of this dengue, which was the new disease, and they returned to their homeland, and then they were appointed as master trainers for dengue control program. And this was when the Dengue Expert Advisory Group was formally launched. Dengue Expert Advisory Group is a group of clinical experts which looks after the clinical management of dengue in the hospitals of the patient, devises guidelines and algorithms for the treatment, and gives advice to the government for preventive and control measures. I am chairing this organization since last year. So this is some of the development of some of the reporting forms that we have developed, because only when you report the disease you can take necessary action. So these are some of the documents which are designed by Dengue Expert Advisory Group. We have established dengue counters in the hospital, in which under one group, the whole diagnosis of the patient is done and the reporting is entered on an electronic dashboard from where the case response is done. We have also developed our guidelines. I'm very pleased to share with Dr. Rose that we did take some of the guidance from Malaysian Good Clinical Practice Guidelines, and our guidelines are based on this, and there was an input from Sri Lankan experts as well, and Thailand WHO Collaborating Center and Singapore WHO as well. So these are the guidelines that we have developed. We have recently updated them last year, and we're also working on dengue good clinical guidelines in the pregnant females. So then we started the training of the doctors on these protocols that we had devised, and continuously we had collaboration with the international experts who gave us advice on how to improve our system, both on the clinical side, control, and the prevention and control side of this disease. We have taken some marvelous IT initiative which has helped us a lot in revamping our system. The existing system was manual, but we changed it to an electronic system. This was vector surveillance, dengue tracking system, patient reporting system, the DVR, which is the dengue virus report application, the third-party validation application, and recently we have launched the general practitioners applications. So a commendable work by our Information Technology Board of Punjab, which have given this wonderful opportunity to all of us to be on one page through these IT initiatives. And I will be sharing some of these with you today. So the dengue surveillance system consists of an anti-dengue application which works through a smartphone. You can download this application from the Google Play Store, and the Apple and Android Store both have this application. It's free to download, and there are small icons which are showing you the activities in the field that the field supervisors and the field staff needs to do. They do these activities in real time, take a before picture, do the activity, and then upload an after picture, and this is recorded in the system. So the users are provided with a username and password. They just have to log in, and whatever they do during the day in the field is recorded in this system. We also have a dengue surveillance system. The dengue surveillance system is, this system reports the larva, and you can also audit these activities by a third-party validation. This third-party validation application is also available on the Play Store, and it supports the administrative staff to look at the field workers if they are doing their services diligently, and they supervise, monitor, and audit these field activities. We've also launched this GP's application. We had a patient disease reporting system from the hospitals previously, but we always felt that the major chunk of the people, they go to general practitioners, which are not part of hospitals, but treating patients on outpatient clinic. So they need to be in the loop. So we have developed this application in which the general practitioners, they register and then they report the patients through this mobile application. So the working system, if I give you an overview, there is a dengue tracking system, there is a patient reporting system, and there is a helpline and dengue virus report. So the patient reporting system is that whenever the patient comes to the hospital, it is entered into the dashboard by the hospital administration and labeled as a case of dengue. The patient is then tracked at the home through the home and the workplace address, and a case response is done at that patient's working place as well as home. So the case response is in the form of surveillance of the 12 houses on right, left, front, and back of the reporting house, and all the activities are recorded in the real time through the dengue application. So when the patient reports, then this system comes into place. On the other hand, the other system we have in place is the vector surveillance system. So in the vector surveillance system, the teams do the indoor surveillance and the outdoor surveillance and calculate the Breathitt index. And this gives us a fair idea that what are the areas which need more supervision, which are the hotspots for the year, and we need to put more efforts in them. So the dengue patient reporting system, as I told you, is in the hospital, and the vector surveillance system is in the field. And these two systems, they work in collaboration with each other, because we analyze that if the larva is more in the region, probably the cases are going to come from there. And similarly, if the patients are reporting from one particular area, this gives us a clue that probably we need to enhance our vector surveillance activities in that area. So the patient reporting system gives us information not only about patient's demographic, workplace, occupation, but it also gives us the clinical information, the lab information, the outcome of the patient, the diagnosis, and it helps us improvement of the clinical management of the patient. So the patient's entry on the portal, then the patient is tagged, and through this, a case response, as I told you, that the house is tagged, this is geotagged, and when the tagged house is, the surveillance is done over there, then the larvicidal activities, they are performed over there, thereby preventing the community around the house also from developing more cases in that community. So this is how the case response comes. The patient reports, the surveillance team goes to their house, checks the houses, not only that house, the workplace of that patient, but also the houses around it, tags them, reports this activity on the dashboard, which is then monitored by the administrative staff and analyzed weekly in the cabinet committee meeting. So there are three types of alerts that we use. The alerts are vector-based alerts. World Health Organization have carried out two alerts which we follow. Then there are GIS-based alerts. The vector alerts, they are basically based on the BRCA index, and we have the cutoff value of more than 3% in the indoor, that the vector alerts are generated when they are more than 3, and this marks the beginning of the potential dengue season. So we have a dengue monitoring cell in the Institute of Public Health which manages all this data. And they produce a daily dengue monitoring report, which is then sent to all the stakeholders who can then analyze this report and take necessary action. The WHO criteria is based on suspected, probable, and confirmed cases. An alert threshold is when there are 3 suspected and probable cases of dengue and 1 lab confirmed case. And an outbreak threshold is when there is a single confirmed case and 6 probable or suspected cases. This is when we raise the alerts and the community is alarmed about the situation. We've also developed a GIS-based alert. This is in collaboration with Dengue Expert Advisory Group and PITB, that we mark these patients, and if there is a circle with 1 kilometer radius overlap with one another. So 3 circles, thereby meaning that if there are 3 patients within 1 kilometer radius, then this is a GIS-based alert, and this is a marker that this area needs to be, surveillance should be enhanced in this area. We also have SAC-SCAN alert as a predictive model that depends upon the positivity of larva, the weather data, and the location. So all these activities, the case evidence, they are geotagged, and before patient surveillance and after patient surveillance, the before and after report is analyzed, and the performed activities in that specific area from which the patient, in the specific time period from the confirmation date of the patient, this is all reviewed in the daily meetings. So similarly, the BRCA index, which is higher in some of the UCs, they are looked into, they are depicted as red on the map, and they are flagged, and the local authorities then can take action on them. We also have developed a health complaint management system where people can, lodge a complaint, and this complaint is then resolved within 24 hours. We have also developed a system-generated alert. So whenever there are high number of cases reporting from an area, or high number of larvae from an area, or high number of, any kind of alert is there, we write to the district coordination officer of that area to have a look on it and resolve the issue. We also publish the health reporting system weekly CITRAP, in which special focus is given on the dengue. As addressed by the previous speakers as well, that no dengue campaign can be successful until and unless we have an aggressive awareness and a social mobilization campaign. So we also focus in all of this, and social media campaign is run. We do regular television and radio programs for health awareness regarding dengue. We also use social media in the form of Facebook, Twitter, Instagram. We do special health programs in the community on awareness, and we also have animated videos for children and a cartoon series. Mass message is also sent to the public during the rainy season via robocalls and SMS services. And there are frequently activities arranged to celebrate Dengue Week or Dengue Day every now and then when the need arises, and the walks are done in different parts. There are competitions and there are pamphlet distributions in the streets. And we also involve especially our school children, because we think they are the agents of change, and we get them involved in a very creative way by having essay competitions, a painting or a poster competition, some theater performances, or painting competition, or some tableau or drama which is of their interest, to give the message to them so that they can practice the healthy measures which can help prevent dengue. We've also engaged our education department, and we've started a 0 period in all the educational institutions to create awareness among the students about dengue virus on a regular basis. And this is a 10 minutes class before the regular class every day, and we tell them about different aspects of the prevention and about the common symptoms of the disease and what do they need to do to save themselves from this virus. So regularly, we also arrange the training of the school teachers and the students as well, and tell them about this disease and make them aware of the preventive strategies that they need to adopt in order to prevent from this deadly disease. And the impact of all this program, these IT initiative, clinical management of doctors, the trainings of the doctors and the nurses, the development of guidelines, the community involvement, the social mobilization, the awareness campaign has been huge. And the impact is shown by the figure that the number of dengue cases also have decreased a considerable level, but also our case fatality rate has markedly reduced from the previous years to less than 0.004 as compared to the global case fatality rate of 2.5%. So recently, we had a huge epidemic, I told you, in 2019, which was consistent with the dengue cases surge all over the globe. And we had a bad year, so we decided to take learn some lessons. What were you be lacking? And we took input from international experts, and we held an international conference on dengue in the early part of the year in January 2020, before the COVID. And we were very graciously joined by international experts from Thailand, from Canada, from Brazil, from Singapore, from Malaysia, Indonesia, and Sri Lanka and UK. And we discussed in 7 thematic areas, including the clinical management, communication, vector control measures, IT development, field work, integrated vector management, communication strategies. And we all discussed in different workshops and tried to revamp our system. We were also recognized by ISNTD who gave us an award as the best application for dengue activity tracking system. And now we propose that, looking at the impact of this disease and the huge army of the mosquitoes, which is not going to deter its actions and is spreading like a fire, and we know that the number of cases are increasing with every passing day. So we need to create awareness about this disease by raising our voice at all forums, and today's activity is one such initiative, where we strongly propose that if other diseases like World Malaria Day or World TB Day or World Mosquito Day can be celebrated, why not World Dengue Day? So this is my message for today. These are the collaborating partners, and I am very thankful for your patient listening. If you want to get in touch with us, you can reach us through our website and our email address. Thank you very much, and I look forward to your questions.
Thank you very much, Somia, for that wonderful presentation. And we were compelled to give that recognition award in terms of the app. I always say that, but we were blown away by it, especially the third-party validation of the data, and just the way it brought lots of different inputs together in one kind of setting. We thought it was fantastic when we saw that. You mentioned some of the cartoons as well in terms of the engagement at public level. Absolutely vital, and I think it's hats off in terms of the containment and the approach that you guys are taking. So thank you very much for highlighting that. So we are supposed to finish this session at 1:45, so we've got about 6 minutes, unfortunately, for the discussion phase. But so we had a lot of questions that we wanted to ask, but I thought I'll condense some of those. I'd like to ask that, when COVID first started, the COVID situation had a impact in terms of the NTD programs. Mass drug administration programs were down, were halted. A wider impact on vector control activities because of the social restrictions in place. That's on one hand, but on the other hand, we've also seen that communities are really, there's an increase in wash activities, there's this increased sense of ownership, and adherence, compliance to hand washing, and this type of thing. So the question is, on balance, do you think that COVID has been only detrimental to vector control? Was it offered kind of a new area of opportunity, and raised awareness, commitment by communities. Are there? What's your take on it? How has it? How has this impacted? Has it been detrimental? Has it been? I don't want to use the term positive because COVID is not a positive thing, but to take something from this, what are your views on that? I'll ask Richard Allan first.
Thanks, Kamran. I'd like to say every country we work in, we've managed to put COVID-19 into the program within really a week to 2 weeks of the start of this real pandemic. And I think the reason for that and why it's been very successful and easy to deliver is because dengue control at vector control level requires such close contact with communities. We reach the homes of 10.5 million people every year. That's, on a scale of some of the countries we're talking about is modest. On a scale of humanitarian crisis, it's moderate. But those are real contacts. They're in homes, they're around homes, and it's building trust with communities and those households. So actually being able to add in COVID messaging on top has been a very simple affair to put more messaging onto a community activity that takes you to the house. And very importantly, because vector control does not require pulling people together en masse, you're meeting them in their own homes, social distancing has not been a problem either. So I put the positive spin on and say, 10.5 million people reached within 2 weeks of the outbreak starting, adapting 10 country programs. It's not been the challenge that many might think. It's actually been a very easy fit.
Fantastic.
And vector control provides the tool for much more like that.
Fantastic. Thank you for that, Richard. Should I quickly get Valentina's take on that? Valentina, are you there? Is that?
Yeah, no, definitely. So we are very much looking at the silver lining of COVID and what are the opportunities. In particular, the touch points are extremely important. We've had to massively scale up digital health. We've had to be far more extensive with scarce resources. So the opportunities are multifold to, again, get at the real priorities of communities. As I mentioned, there's been huge amounts of necessity to engage at the community level, to empower communities to protect themselves. And in all of this messaging, we're using the wedge that we have. From my perspective, of course, on malaria, because we were very fast out of the gate vis-a-vis the symptoms, it's been an incredible learning opportunity on how we can do health system strengthening, and again, use your local contact points. So stop kind of all the parachuting in, but use the incredible resources that we have at local level. You have two extraordinary women presenting on behalf of Pakistan and Malaysia, and they are the tip of the iceberg of many extraordinary doctors, community health workers who are working around the globe.
Thank you very much for that, Valentina. I totally echo that. And just coming to those two amazing women for a second, and building on what you just said there, it would appear, and this is to Dr. Rose, I suppose this is to both Dr. Rose and to Dr. Iqtadar, the real-time surveillance that you mentioned, you said that when the MCO started, the movement control order, there was no real discernible decrease in the real-time surveillance because it is real-time, i.e. tech-based, and you listed some of those apps that you're using. And Somia, Dr. Iqtadar, we'd given you the recognition award for the amazing app that you guys had developed, and that was with a partnership outside of the Vector-borne disease with the IT tech board of the government there. So the question to both of you is, if this is now the new norm, stop, start, social restrictions, it's going to be here for some time. How do you envisage developing that tech approach to surveillance and indeed addressing some of the other issues around community engagement, involving them more? How do you anticipate, or are there plans to further develop that particular approach?
Okay, may I respond first? Yeah, okay. Actually, this real-time web-based surveillance not only how we look at the advantage of this surveillance. For example, if a doctor see a patient from their hospitals or clinics, they can already notify the cases, the dengue cases from their clinics without going to the nearest health districts as previously. So previously they need to send a form and either they fax or they send the forms to the nearest health district. Now they can do it from their clinic and hospital, just enter in the systems and we get the information immediately once it's in the system. So this also initiate us to a lot of information can be taken from this real-time web-based surveillance. We have a surveillance system that automatically can alert you if there's an outbreak occur, because we have a GIS mapping of each of these cases. We have also iDengue, where we share the dengue information with the community. It's also a real-time. We update the cases and the deaths every day. They know where are the hotspot, the outbreak of the area. The community can assess that. And we have systems for our health staff where a dengue alert can be, dengue outbreak can be alerted from the system. If there are 2 cases, for example, and in nearby, within 200-meter radius, the system will alert, oh, there's an outbreak in this area.
Wow.
So immediately the control measure can be done by the districts. So previously they have to do that manually.
Yeah.
They have to look at the map and they have to go down and investigate. Now we have the GIS mapping and it's alert the staff. So this is early warning for the staff to initiate control measure as soon as possible.
Fantastic. And Dr. Iqtadar, do you see this tech approach evolving further? Is becoming a new norm within the norm of social distancing, vector control in the age of COVID? I'm trying to say the importance of the app and the importance of that kind of approach to the communities that we're talking about. You have to unmute your sound. Sorry. Yeah.
So definitely, I think without innovation, you just perish. So you need to do something more and add on something more to improve your system. And that's what we do every day. We started with one simple vector surveillance ad. We then added the patient reporting system. Then we added the third-party validation. Then we added this GP application. So every day is a new day and something new idea comes, and you know, the idea comes to the clinicians probably because they're looking around to the patients, but it has to be implemented in a very technical way, and that needs a lot of input and obviously technological support. So in the COVID time, because there were a little restriction on the movement and we had a lockdown situation, so there was a small gap and decline in the activities recorded on the system because the actual field visits of the teams, they were restricted. But we were definitely looking at other aspects because the patients, they don't stop reporting to the hospitals. And if the patients are reporting from one particular area, so as shared by Dr. Rose, we also have that GIS system that if there is an overlapping area in a 1 kilometer radius, there are 3 patients, then this is an alert. And the team goes there and does a sweeping activity in whole of that area and whole of the locality to look at what is the culprit over there and identify it. So I think that the system somehow finds a way to work. So if once one road is closed, it finds another small side way to, you know, get to its point. And this is the new normal, and we have to live with it and bring some innovation in the system to cope up with this thing that we have to do. Yes.
Thank you for that, Dr. On the word innovation, I mean, is there scope for you guys to get together and make a super set of tools? Because by the sounds of it, something for education, for you're educating these communities, something from the UNICEF's perspective, you're already working on tool sets. Obviously, these 2 tech approaches are definitely working. So is there scope for a kind of super set of tools? Is that the new frontier of partnerships for NGOs?
I think that's a brilliant idea if we could, you know, exchange our communication material, the way we communicate with the, but you have to, you know, tailor it according to the cultural norms and the regional level. So maybe we can exchange ideas and come up with a basic theme and then fine tune it according to our own circumstances and then do something about it. I think it's a great idea.
Well, we'd love to see something like that happen. This is why we're kind of trying to galvanize a focal point, an event horizon, the World Dengue Day. We think there's so much obviously going on in all the different sectors. I mean, this is vector control from a community, sustained community perspective. We've got vaccine hesitancy. We've got issues at climate level, climate change level. All these things, they need a point to kind of coalesce around, and that's kind of driving force behind asking for a World Dengue Day. So I wish we had longer to talk, especially about this partnership, because I know some of the tools that UNICEF have mentioned, and I'm aware of some of the tool sets that you do. And I know your education programs could definitely benefit from something of that nature, Richard, as well. But we're going to have to say thank you very much to everybody now. And I'm going to have to say virtual goodbye and get ready for the next session. So I really hate doing this bit. I'm much more a people person. Yeah. But thank you very, very much
Thank you.
for coming.
Thank you, and lovely seeing you all.
Thank you.
Bye. Allah
Thanks a
Hafiz.
lot. Bye-bye.